Hi guys, welcome back to the channel. Today we discuss basic trial based on balance solution versus normal saline injection study. This is randomized control trial.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of some whatever. Under any circumstances, the author accepts no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Clinical question. In adult intensive care patient, does the use of balanced electrolyte compared with the 0.9% saline reduce the 90 days all-cause mortality? In adult intensive care patient needing the administration of resuscitation fluid, does the slow infusion compared with the fast infusion of a fluid bolus reduces the 90 days all-cause mortality? Background. Almost all patients in ICU receive the intravenous fluid. The SPLIT and SMART trials compared the plasma light versus 9% saline. The SPLIT trial with a median of 2000 ml administered in each arm showed no difference in 90 days acute kidney injury. The SMART trial with a median of 1000 ml and administered in each arm showed the significant greater 30-day occurrence of major adverse kidney events as a composite of their NEO-RRT or persistent renal dysfunction. Use of rapid boluses, very common intervention in unwell patients has been opportunity to result in unfavorable cardiovascular physiological outcomes such as reduced arterial elastance. The FISH trial showed that African children with hypertension, the use of saline or albumin boluses resulted in increased risk of 48-hour mortality. The FINANCE study looking at fluid bolus administration in over 2000 ICU patients found that the practice was very variable with regards to volume, rate and endpoint. All study will be discussed in the further lectures or further studies. Design for this study is a factorial 2:2 randomized study. Randomized to 1:1, 1:1 ratio at each fluid balance solution. Plasma light 0.9% sodium chloride and each rate of administration is a 333 ml per hour or 999 ml per hour. Randomization via online software in a random permanent blocks for 12 patients. Those who involved in patient care were blinded to fluid type but not at the rate of administration. Fluid supplied in identical 500 ml bag labeled with a letter AF. Data protocol adherence check on a day of 1, 2, 3 and 7. Follow-up phone call day at 90 to assess the vital status and need for RRT. Power calculation. Planned sample size 11,000. Base of 30%. 90-day mortality rate in control. 0.9 sodium chloride versus rapid infusion. 89 power to detect the hazard of ratio 0.9 or less. 90-day mortality with alpha level of 0.505. Absence in the interaction between the fluid type and fluid was assumed. Pre-specified secondary tertiary outcome and subgroup. Ideally prospective inform consent sought but the differ consent allowed. Appropriate ethical approval gain. Setting for this study 75 ICU in Brazil. Data collected from 29 May 2017 to 2nd March 2020. Population for this study is the inclusion criteria. The admitted to ICU with the need for fluid resuscitation and defined by the one sign of hypoperfusion or one sign for fluid responsiveness. Not expected to be discharged the day after the admission. At least one risk factor for AKI, age 65, hypotension, sepsis, mechanical ventilation, oliguria, rise serum creatinine level, cirrhosis or acute liver failure. Exclusion criteria: age less than 18 years, RRT or expectation to require RRT within 6 hours. Fever electrolyte disturbance, sodium less than 120 or more than 160, potassium hyperkalemia more than 5.5, death expected within the next 24 hours, suspected or confirmed brain death, recipient to palliative care treatment only, tried enrollment, 11,052 patients randomized, 486 successfully refused the consent, 46 duplicate the randomization, 25 lost follow-up at 90 days, 5,290 randomized to receive zero point 0.9 sodium chloride, zero point 0.9 sodium chloride at a rapid infusion rate, 2,641 patients, zero point 0.9 sodium chloride at a slower infusion rate, 2,649 patients, 5,230 randomized to receive solution, balanced solution rapid infusion rate, 2,603 patients, in balanced solution at a slower infusion rate, 2,627 patients. Comparing baseline characteristics of intervention versus control group, baseline characteristics similar across all groups. Selected baseline characteristics: age, sex, source of ICU admission, elective surgery, SOFA score medium, medico criteria for AKI, SEPSIS, hypotension, NAP less than 60, histology less than 90, vasopressor use, invasive mechanical ventilation, serum creatinine, traumatic brain injury, heart failure, and in the 24 hours prior of enrollment, any fluid administration prior to randomization, recipient more than 1 liter prior to randomization, recipient receive more than 1 liter balanced solution prior to randomization, recipient receive 1 liter 0.9% sodium chloride prior to randomization. The age 65, 60, mean is 60, sex 45, 43, 43, 45, sex female mostly, source of ICU admission almost ICU, SOPA score 4, PDCO mean 30 to 31, and sepsis 17 to 19, hypotension 60 almost, invasive mechanical ventilation rate 44 to 45, serum creatinine in 81 to 79, and traumatic brain injury 5 to 4.5, heart failure 10 to 10. Intervention. To intervention were assessed the use of balanced fluid plasma light giving a slower rate of infusion 333 ml per hour if fluid boluses were required. Control group. Two controls were assessed. Use of 0.9% sodium chloride giving rapid rate infusion 999 ml per hour if fluid boluses required. Management common to the both groups. Fluid that patient randomized to was used to entire ICU stay. Guidelines provided for when a fluid challenges is required and when to commence RRT. Use of resuscitation maintains the drug digestion if possible. If a fluid indicated, maintain. Give fluid study. Fluid patient randomized. Fluid boluses given study fluid that the rate of patient randomized. Other fluid bicarbonate, albumin, blood allowed. Volumes and frequency of administration at discretion of a treating clinician. In some scenarios, severe hypernatremia study fluid not allowed, so can alternate fluid. Use of study fluid that used to resume as soon as contradictions resolve. Outcome: fluid type sodium chloride versus balanced solution. Primary outcome: no significant difference in 90-day mortality. 1,381 patients of 5,230 patients, 26.4 assigned to the balanced solution died versus 1,439 patients out of 5,290 patients, 27% assigned to the saline solution. Secondary outcome: SOPA score at day 7 significantly different for the balanced solution group, medium difference 0.27, mostly due to the higher neurological SOPA score more than 2 at day 7, 72, 32, 1% versus into 26 in a saline group, odds ratio 1.40. There is no statistical difference in the other 17 secondary outcomes, including incidence of AKI with a need of RRT within a 90 days per 1000 patients per day. Subgroup analysis: statistically significant interaction between the presence of traumatic brain injury, fluid type, 90-day mortality, 31.3 for the balanced fluid solution group versus 21 for saline group, 26.2 versus 27.5 patients without a traumatic brain injury. Fluid type primary outcome 90-day mortality 26.4 in balanced solution, 27 in 0.9 percent sodium chloride, and RRT within hospital admission 7.5 or 8.1. CDGO score more than 2, 27, no difference. CDGO score more than 2 at the day 7, 23. Mechanical ventilation 3 days at the 28 days, same 27. Subgroup analysis, sepsis, no difference. 90-day survival 453 versus 498. AK CDGO more than 2, 392, 444. More than 1000 ml of 9% sodium chloride administered in a 24 prior to randomization 193 versus 203, and traumatic brain injury 78 at 50. Fluid rate, rapid versus slow administration of fluid challenges. Primary outcome, no significant difference in 90 days mortality in lower incidence group. 1400 out of 500, 476 patients. 26 had died by the 90-day mortality with 1,414 patients out of 5,244 patients. 27 in the control group. Secondary outcome difference in day 3 cardiovascular respiratory population SOPA score significant. By day 7 no difference in SOPA score significant. Day 3 cardiovascular SOPA score lower in lower group 32 versus 35. Day 3 respiratory SOPA score lower in lower group 6.2 versus 7.5. Day 3 population SOPA score higher in lower group 4.7 versus 3.9. Fluid rate primary outcome 90-day mortality. 90-day mortality slower in 26 and rapid 27. Selected secondary outcome RRT within hospital 7.5 versus 8.1. CDGO score more than 2, 26 versus 28.4. Day 7 CDGO score more than 2, 23.6, 23.1. Day 3 cardiovascular score 32 versus 35. Day 3 respiratory SOPA score more than 2, 6.2 versus 7.5. Day 3 coagulation SOPA score more than 2, 4.7 into 7.9. Mechanical ventilation 3 days is the 27 and 10%, no difference. Then for this ICU, an extremely large multi-center trial designed to answer an important clinical question given the intensity of fluid used in ICU. Excellent internal validity proved randomization strategy. This strategy was tested and when the principal investigators were asked if they could guess which fluid which later corresponded to the 6 by 56 who replied correctly guessed the association between all the later fluid types. This was compatible with the hypothesis that answer based were randomized. Appropriate blinding for fluid type, not blinded for the rate. Minimal loss to follow up. Balanced baseline characteristics. Pre-printed statistical analysis plan. Sensible secondary outcomes and pre-specified subgroup. The authors rightly identify these being the hypothesis generating only. To complete process and write up such a large methodological rigorous RCT in the mid of Brazil COVID-19 sequences is impressive. Witnesses no analyze as an intention to treat, given that majority of those who did not receive treatment as a randomized due to the withdrawal of concern. This is unlikely to clinical relevance. Mortality lower in 90% in a power calculation may reduce the power of study to detect the important difference. Mostly lower ACUTE ICU patients. Median aperture score 12 and SOPA score 4 or nearly 50% is literally surgical and 40% not hypertensive. Median volume of prior fluid administration were low, less than 1 liter per day, making a difference in outcome potentially less likely to be detected. 24-hour study fluid 1.5 liter in each group. 72 hours total study fluid 2.9 in each group. 72 hours total fluid study and non-study fluid. Administration of non-study fluid will be confirmed result. 68% of all patients received fluid prior to randomization. Sodium chloride received more than 1 liter received fluid and 18% in the balanced group more than 1 liter 0.9 sodium chloride. Following randomization of the total fluid received by the day 3 was not studied crystalloid. Additionally, dextrose, albumin, synthetic chloride were also transfused. Chloride load hypothesis to be reason increase the mortality organ failure weakly. Mean serum chloride levels were higher in 0.9 sodium chloride group at 48 hours. This was only 2 milliequal above the upper limit of a normal range, which is not meaningful clinical importance. The slower infusion rate was defined arbitrarily 333 ml per hour. Author provide explanation that this is the less than 25 percentile in the fluid challenges in intensive care. The finance squad study, which is still represented a value that is considered as a bolus, not a maintenance by clinician. No data collected on a region of identification of fluid boluses and immediate hemodynamic effect. Author conclusion: among the patients in intensive care unit, use of balanced chloride compared with 0.9 sodium chloride did not reduce the 90-day mortality. Use of slower infusion rates where fluid bolus is required compared to the faster rate of infusion did not reduce the 90-day mortality. The bottom line: on the basis of this trial, the use of 0.9% saline sodium chloride in ICU after stress due some of the limitation about the conflicting data from the other trials. I will continue the use of balanced chloride for those patients who are acutely unwell within unplanned ICU admission. Although the secondary outcome are hypothesis generating, it would be seen to resemble to use of 0.9 saline in a traumatic brain injury. The need of for the rapidly administration fluid boluses for intensive care patients would be the we are on an individual patient basis rather than the respective option given lack of benefit and potential harm. So the plus trial will be continued to inform that some trials will be explained in next lectures and videos. Please continue to watch my channel. Thank you.